Okay, we're going to continue to section 200, operating room policy, environment, and procedures. Section 200 is a very large section that has to do with the OR. So it's about 10 pages, so I'll probably put this in maybe 2 or 3 segments. All right, 200.10.10. This is Class C, so this does apply to us. A surgical pause or a timeout protocol is in place, practiced and documented prior to every surgical procedure, and is documented in the operative chart. So we're talking about in the patient chart. The protocol should, and that would be on the anesthesia sheet, right? Everybody knows that. Plus there's another sheet. The protocol should include a preoperative verification process, including the medical records, imaging studies, and any implants identified and being reviewed by the operating room team. Missing information or discrepancies must be addressed in the chart at this time. Marking the operative site, the surgical procedures calling for the right-left distinction, multiple structures, breasts, eyes, fingers, toes, etc., must be marked while the patient is awake and aware, if possible. The person performing the surgery should do the site marking. The site must be marked so that the mark will be visible after the patient has been prepped and draped. A procedure must be in place for patients who refuse site marking. So for plastic might be different, okay? I don't know what kind of markers. I know the surgical site markers that we used for the orthopedic and podiatry marking, right? I don't know, since plastic often marks up on the face, but I've never had anyone refuse marking. They wear it like a badge of honor, but I get it on the face, right? So you do have to have a procedure in place for patients who refused or who will or may refuse site marking. There's not many that will, and you probably would know who they are ahead of time. Timeout. Immediately before starting the surgical procedure, conduct a final verification by at least 2 members of the surgical team, confirming the correct patient, surgery, the site markings, and as applicable, the implants and the special equipment or requirements. As a fail-safe measure, the surgical procedure is not started until any and all questions or concerns are resolved. Procedures done in non-operating room settings must include site markings for any procedures involving the laterality or the multiple structures, which we had toes, right, or fingers. Environment, point 20. The facility displays a professional appearance that is in keeping with the medical facility designed to carry out surgical procedures. The facility should be neat, comfortable, clean, and should include a waiting area, a business office, and a sanitary lavatory facilities. 1 or more dedicated exam rooms should be available that provide for privacy and treatment in a sanitary, orderly environment. The operating suite is physically separate from the general office. So the environment is going to include a lot of the facilities manager, and this goes back to the original drawing of the surgical suite, right? How you're setting up the rooms, the flow, everything like that. All right, point 15, the operating room suite includes operating rooms, a prep scrub area, a clean area and or dirty area, and a post-anesthesia care unit. So you'll see further in this chapter, you can share areas, but there has to be sterile clean in between the use of them. There is a room dedicated for use as an operating room. We don't have 25 because we're not C. We're looking only for C. So we're going to go here to the deal. Point 30. All major surgery is done in the separate and distinct operating rooms. All right. The operating room is adequately ventilated and temperature controlled. Let's see, what is that, 35? And what we would need is going to be, you do have to have the thermometers, thermostat, just to make sure that in case it gets too hot, who's going to be leaving the room to change the temperature. Again, if it's inside the room control, then anesthesia can get up and do it, or the circulating RN, right? 0.50 is the operating room is properly clean, maintained, and free of litter and clutter. I've seen it turn into places where they do keep a lot of equipment. The deliveries will come in. I would ask you to avoid putting anything into the OR until you need to put it into the OR, right? Because you want to keep it sterile. Otherwise, you're just cleaning more and worrying about transferring more germs. All right, so we're going to operating room. Here we go, 0.55, or C right here. Each operating room is the size adequate. I apologize. Each operating room is of a size adequate to allow for the presence of all medical equipment and personnel necessary for the performance of the surgical procedures, and must comply with applicable local, state, and federal requirements. Additionally, all facilities must have a minimum of 4 feet, 48 inches of clear space on each side of the OR table to accommodate the emergency personnel and equipment in case of emergency, and permit the safe transfer of the patient to the gurney for transport. Or facility personnel can physically demonstrate to the surveyor that the emergency criteria stated above can be met in the operating room space available. So what we're doing on this one is, I know it's a no-brainer, but I've done little surgery centers and grand ones, right? So you're going to want to, everyone for your PACU, right? So you're going to want to have your PACU recovery bed to be able to go right into the OR. So that just makes sense right there to be able to do it. But you need people to stand, right, to pull on the transfer, to bring them over. So always map out when you're doing your drawings on your facility and your layout that you are able to get around. You know, you can't have the anesthesia cart where the gurney has to go, right? So, or the O2 or anything. So have to work through how to be able to save everybody in case they need to, right? 0.60, there are no overloaded wall plugs or overloaded extensions in use. No altered grounding plugs in use, and wires are not broken, worn, or unshielded. I've had the privilege of working with new build-outs, so we were able to put all of the outlets where we knew the equipment was going to land for the most part. And I highly advise against the use of any extension cords at all, and especially during inspection, right? So just make sure everything's covered, safe, just like if there was a kid walking around, right? But if there's liquid or stuff spilling or flying, you want to be able to keep everybody safe. 65, unauthorized individuals are deterred from entering the operating room or suite, either by locks, alarms, or the facility personnel. And everyone, that's pretty easy. It's just a sign. Check in here, right, front desk. We had some where one of the surgery centers I did as a consultant had a unique structure where they actually had a telephone by the lobby door. So all the staff was inside the nurse's station, the PACU, and the OR were all inside the other side of the door, and it was locked. And you can't get into that unit, right, without a code or, however to get through. So either there's locks with the punch codes, right, so staff can come and go, or there's the phone method where you can pick up the phone and get the receptionist, like if someone's handling clinic in another part, they'll get that and say they need to use the restroom if you don't have a restroom in your patient waiting room. So that's what we did. We did locks. The alarms we didn't do because the doors were always locked shut. So I haven't done alarms yet. All right. That's facility manager would handle that, right? The signs, I don't know. I did the signs, but I have to recommend InPro for signage, INPRO. They are in New Berlin, Wisconsin, and they have beautiful, we got a lot of our curtains there. They custom did the signs. They do all the hospitals in, most of the hospitals, all right, in Milwaukee. And for the drapes, it's environment. They work with environment. So signs, custom make whatever you want. They'll do whatever you want. I've done so many custom signs. So you have less signs, right? You have signs that are simpler and just direct. So that's how it is. 0.75, sterile supplies are labeled to indicate sterility and are packaged and sealed to prevent accidental opening, which is, the tape, the seal tape. So each sterilized pack is marked with the date of sterilization. So as you start using your sterilizer, definitely mark what date it was sterilized, because if the infection or something does come around for a surgery with a piece of equipment that was sterilized in a batch with that batch, then they would know to go back and re-sterilize the whole. With the expiration date, when more than one autoclave is available, we had different color tapes, right? So that's how we could tell the difference between. Each pack must additionally be labeled to identify which autoclave it was sterilized in. 85, if one sink is used for both dirty instruments and to scrub for surgery, there is a written policy to clean and disinfect the sink prior to scrubbing hands. So I've had ORs, right, where we had that. It was clean prior to surgery. They had their tray with all of the instruments and everything in it. Nobody really threw anything anywhere because everything's expensive. So you don't want to, dent or kink or pinch any instruments. They get beat up enough, right? So it would be on a tray or a bucket. And then whoever did the sterilizing mostly was the surgical techs and the RNs that did the sterilization. And then the last one, the Medicare one, the Medicare one had a sterile room, which was kind of nice. So it passed through a window from the OR, so you didn't have to walk. And then from the dirty, then they'd rinse it off there, and then it passed through to where the sterilizer was, and there's more tables in there where they could, wrap it up with the papers with their wrap. So that's how we did that. All right. 090 applies to us. If a pre-existing sink is present within the operating room, a written policy to prohibit the use of the sink during sterile surgical procedures must be in place. A sink is permissible in an operating room which is exclusively used for endoscopic or urological procedures in accordance with the standards of those professions. Requests for allowance by other specialties will be reviewed on a case-by-case basis. So when you are putting in your plans, the OR is just, think of the OR as just sterile all the time, no matter what you're doing in there, right? Even people you allow to pass through it shouldn't be in there unless they're there for the procedure and they've already gone through the whole sterilization protocol. Storage, there's adequate operating room storage to hold the equipment, sterile supplies, and medications. Storage space should be adequate to minimize the need to leaving the operating room for frequently used supplies, equipment, and or medication. Everybody knows that one. The medication, we had 2 safes. One was in the RN station for the PACU meds, right? To put the patients under anesthesia and, for any complications. And then we also had the anesthesia cart, the crash cart. So depending on where you're getting your meds, anesthesia, a lot of times, Windy City anesthesia, we used for almost everything, Dan Borvan, and they actually brought in the meds, which was nice because we didn't have to do all the mess with the, what is the name of it? The medicine, like, come on. That's escaping me right now. But you have to get your license special to your surgery center if you're receiving fentanyl or propofol to be delivered there. So the anesthesia team coming in, they stock the cart, right? They have the key. They're the only ones with the key, and they stock the cart. And then you don't have to worry so much about the meds expire, because what they'll do is they'll move it around between all of their surgery centers, per se, right? In their boxes. So especially when we get to the malignant hypothermia, the medicine or the injectables that they use for that rescue has an expiration date. It's very expensive for small vials, so and to eliminate waste, right? Equipment, we'd have to move the C-arms in and out, right, for different procedures. Some procedures, some doctors had endoscopes and all that. So whatever doctor was working in a multi-specialty, I had multi-specialties I worked with, so we'd have to push the C-arm somewhere, right? And C-arms are very expensive equipment, luckily on wheels, but you want to be able to not have to scrub it down if you're not using it, because anything in the OR needs to be scrubbed down after a surgery. And then the sterile supplies, we usually had cabinets with glass fronts. The surgical assistant, or the RN that set up the cases for the day, we had it where they could even pack. We had it where their bins were made up with all of the implants, and usually the traditional opens, closed materials, the sterile packs. She would set it up so that if something happened, everything would be pulled for the next surgery. But it was nice because you could see all the sterile supplies through the glass windows. So there wasn't a bunch of opening doors and banging doors and, moving the wind around even more, right? We want less, right, pushing around the germs. So sterile supplies, make sure you order what you need, not more, right? Because you have to store it all and you have to use it, because stuff does have expiration dates. And I've seen a lot of very expensive surgical gloves go to waste. Class C, number 10, storage space provides easy access for identification of inventory of supplies, which goes with the glass cabinets again. And that is the benefit because you don't need to open every cabinet and have somebody touching things, right? You just look through the glass and you're like, okay, I have this many of this suture, okay, and you just keep going down your list. And when you're setting up your inventory sheet, I would set it up from your left to your right by the cabinet, so it's easy. So if you can just do only one cabinet in a day, right, however you're working on your inventory, but go around the room. Sterile supplies are stored away from potential contamination in closed cabinets, drawers, or away from heavy traffic areas. So again, these would be in the cabinets with the glass, and we usually have them around the table, but we try not to go, right? You pull everything that you need. So it's only if something arises while you're in the surgery, because we know nothing is the same. No surgery is ever the same. So you want to just be able to not contaminate more than you need to. Even if it's a sterile, everyone's touching something in there. And right, with this COVID, everyone's a little bit more aware of what sterile means. Granted, we're trained in sterile in this environment, but sometimes we don't see what we don't see. So limit the people pulling on the drawers to the qualified personnel that aren't looking for things, right? Sounds good? Okay. I think I will stop this right here and start the next one.